Hello everyone, my name is Rita Vassena. I'm the scientific director of the Eugin group, and I'm very happy to be here with you today to discuss about testing and assisted reproduction. The title of my talk is Testing Before Birth, the Evolution of Reproductive Testing, but I actually took the liberty to change it a little bit to testing before pregnancy, given the very large perimeter in which we move when we discuss genetic testing and reproduction. So what we will discuss today, this talk will be about mostly carrier screening and expanded carrier screening. What are their origins, if they are justified, and what are the opportunities that we have by introducing this test, but also what are the problems that arise. We will use also a discussion about the use of preimplantation genetic testing, specifically when we have as a response or as an ancillary technique to ECS. And I would like to finish this presentation by introducing to you three clinical cases that are real cases that we have witnessed in our clinics, and not in order to find, of course, a perfect answer or a perfect solution, but to reflect a little bit altogether about the kind of problems that may arise when we apply genetic testing in the context so delicate and as human reproduction. So what is carrier screening? Carrier screening is basically the classical version of it is a screening or is a genetic test that is done on healthy persons that do not present any phenotype and they're not sick, but they are pertaining to a group that is at a higher risk of hereditary genetic diseases. This is not a diagnostic test. The person is not suffering from any type of disorder, and therefore it is not used to confirm a phenotype. It is just used to identify people that are at risk of transmitting the disease that they carry to the next generation. This is not a new concept at all. It is in fact a fairly old one. It used to be called ethnicity-based carrier screening, and some of the most successful and earlier programs dates back half a century. The Cyprus Thalassemia Control Program is very famous. Back in the days, it wasn't even genetic screening, it was based on protein expression in blood. But basically it consisted in testing anyone in the Cyprus community before they would get engaged and married, so that to identify couples that may be at a higher risk to transmit thalassemia to their children. Along the same line, the Dor Yesorim program in the US that was implemented in the community of Ashkenazi Jews screened for Tay-Sachs disease and allowed actually in just a couple of generations to lower incredibly the incidence of the disease in the population. Even though it is not unfortunately universally known, in the US the NIH has been suggesting and recommending since 1997 that everyone that is planning to have children should get screened for their condition of carriers for cystic fibrosis, since this is among the rare disease, one of the most frequent one in the population. One of the countries, perhaps the country that has most strongly and thoroughly implemented the idea of carrier screening is without doubt Israel. Israel has a very long history of using carrier screening to support its own population growth. In 2013, it has become the first and, as far as I know, the only country that offers free screening to his citizen for all disease that has a carrier frequency that is higher than 1 in 60. And this is very important because it goes from screening for 1 or 2 disease to a much wider group of conditions. So this brings me to the concept of expanded carrier screening. It is really in the name. Expanded means that now what we are doing, we are able to test, again, healthy people without a family history for hundreds of serious genetic diseases. Because now we are testing for hundreds of diseases, of course, the individual does not need to be part of any high-risk group, since so many diseases are screened at the same time. The diseases that are included in ECS panels are autosomal recessive, or they have an inheritance that is X-linked in mode of inheritance. It needs to be recognized that expander carrier screening is basically a technology-driven product or a technology-driven service that comes from the lowering of cost of sequencing, going from Sanger sequencing, which is manual for the most part and labor-intensive, to next generation sequencing that is vastly automated and much more cost-effective. So when we talk about a panel of ECS, we should first ask ourselves, what disease should we test for? And I've discussed before that we should put serious diseases, but then what is a serious disease? Well, there is, of course, an agreed upon definition, which comes from a joint statement from the American and the European Society for Human Genetics. And a serious disease is considered some condition that lowers significantly the quality of life of the affected individual, that cannot be cured but requires lifelong management through medical or surgical intervention, and that reduces significantly life expectancy. In order to reduce significantly life expectancy, usually this translates into a disease that becomes apparent, has an onset that is early, either directly at birth or in infancy, or in any case during the very first decades of life. It is justified to apply an ECS panel. It is something that we want. It is something that is good. Well, let's consider some numbers and some data. So we need to recognize, and the more we study our genome, the more we realize this, that we are all carrier of pathogenic variants in our DNA. And this is an unescapable truth and is built into our own biology. Let's consider that each year 8 million children are born in the world with very serious alterations that are caused either completely or partially by a genetic mutation. And it is estimated that between 2 and 3% of all couples in the general population are at an increased risk to have a child that is affected by a serious genetic disease. So are we justified to try and catch these couples? In the context of assisted reproduction technology, the application of ECS has a very specific aims. It aims to identify the couples that have this increased reproductive risk, and since they are already in the process of manipulating their gametes outside of the human body, to offer them an actionable opportunity to decrease this reproductive risk in the next generation. It has to be recognized that this couple that do not usually seek ART treatment for a genetic reason. They usually come to the clinic for an infertility reason. But of course, while they're there, they can take advantage of this test. And as an obvious consequence, ECS needs to be carried out, or it should be carried out, and it acquires the maximum of its efficacy when it's done before getting pregnant. About 80% of the couples that have a child that is affected by recessive disorders, they do not have another case in their family. They are usually very surprised to have children with a disease they have never heard of and they have never seen in their family. And as an example of one specific disease, 95%, so 1 in 20 children, or 19 out of 20 children that are born with genetic hearing loss, so non-syndromic hearing loss, that are then identified, as at birth through the regular screening, they have both parents with normal hearing. And this is the crux of the matter. You have an autosomal recessive disease that can, let's say, run in families without surfacing for generations and generations. So practically, how does it work? It is really pretty straightforward. In Europe, at least, you need a clinician that prescribes the test to you and also that informs about the detail of the test and the kind of result that you may find. The test is commissioned and it's really simple. It's done through a very small blood collection, or even through a swab with a little, or even through collection of saliva. It's then sent to the lab. Is a tertiary lab that is specialized in genetic testing. There, a panel with the number of genes is run, meaning that this DNA is sequenced, is read, and is analyzed. And in a frame of time that is anywhere between 2 and 4 weeks, the couple receives back a report, and in the report it says what mutation, pathogenic mutation and also non-pathogenic mutation, have been identified in their DNA, both of one person and the other. And the report will highlight if there are some mutation in the two people that are on the same genes. So if the mutation that the two people carry are not on the same gene, then you have sort of a green light. Your reproductive risk is lower than the general population, and the couple in the context of ART can get pregnant. But if some of the mutation are present in both people on the same gene, then they have an increased reproductive risk. Since these diseases are all of a recessive inheritance, it means that a couple that have an increased risk for disease X will have on average a 25% chance of having a child that is not carried but is actually affected by the disease. So 1 in 4, so it is considered a very high chance, and therefore there are a number of options for this couple if they want to get pregnant. So the point of doing this test, of course, is to be able to make decision. Just knowing the information and not be able to do anything about it is going to be, of course, useless. So what should couple do? What can they do? If they are in an IVF clinic already, usually the most straightforward or the most logical step is to add to the in vitro fertilization that they are already doing anyway, a diagnosis of the embryos that are going through the process. And this diagnosis is called PGT-M. PGT stands for preimplantation genetic testing. And M stands for monogenic, because we are talking about monogenic disease. There are several kinds of testing we will see, but the monogenic one is the one that applies to these cases. There are other options, of course. One that it might sound a little bit harsh, but is actually often used, is to change one of the gametes, to just use a donor gamete either for the oocyte or for the sperm. So of course this is not the first thing that you think about when you want to decrease your reproductive risk, but let's not forget that in the context of ART, often the couples might need to change anyway one of their gametes, or for age or for other infertility related factors. So if they are already one step away from changing the gamete, this might be an option in response to an ECS that is positive. Other options would be to carry on with the cycle, but then go through a prenatal diagnosis. And another option that are not, of course, common, but it can also be considered, is consider other options to become parents. I would like to stress that in this context, when you have intervention of a clinician, doing nothing is not really considered adequate when there is an clinical intervention. This doing nothing sometimes is expressed by the couple as we will accept the risk. So how should we test? How many diseases should we test for? We established that we can test for hundreds, but how many should we really test for? So these are a list of some, not all of them, but some companies that are very active in in this field in Europe, in Spain, but also some companies are from the US. And you see on the right hand side the list of genes that the number of genes that they sequence in each of their panel. And you see that the numbers, they are in the hundreds all the time, but they vary widely. We go from as small as 176 to more than 600. So which one should we choose? Perhaps one easy approximation would be to, pick the biggest one, because since we are testing, why not test as much as possible? There's always the chance that we catch more positive. But the question is a bigger panel a better panel as well? In this comparison between two panels, one testing 108 genes and the other one 549, you see that the number of carriers varies very significantly depending how much or how extensively you look for mutation. So basically, the bigger the panel, the higher the number of carriers that you will identify, because the status of being a carrier is not a function of who you are, it's just a matter of looking for mutation. So again, should we aim to identify all possible carriers? Should we aim to identify all possible mutation? The answer is really not. We need to distinguish between the size of a panel and how useful it is. In this graph, you see on the x-axis that the more genes you study, the higher the number of individual carriers you will identify. However, our goal is to decrease the reproductive risk of a couple. And if we want to decrease the reproductive risk of a couple, we need to aim to identify the couples that are at risk. So you get to a point in which the more gene you add, the more individual carriers you identify, but because these additional genes that you are adding are related to diseases that are so rare in the population, you're not really going to identify more couples, because it's so difficult to find a couple in which both of them will be positive for this very, very rare mutation. But increasing the size of a panel has some, problem as well, because there are some limitations to the technology. So if you test for a lot of genes, the depth by which you are testing all of them is lower. So you might risk getting to a point in which you are adding genes, but you are losing, exactitude. You're losing depth in your analysis, and this you don't want to do. This is an example of a panel that we are using in some of our clinics, and after about 1,500 tests, we found that we had 4 out of 5 people were carriers for some mutation, some deleterious mutation, and in fact half of them were carried for more than one. How does that translate in terms of couples? Well, with this panel, we found that there are about 4% of couples that are at increased risk, and since this increased risk is about 25%, it means that 1% of the pregnancy that are reaching term are at an increased risk. So in other words, by applying this panel of expanded carrier screening to everyone that comes through the door, we should be able to prevent approximately 1 in 100 developing pregnancy that are affected by a serious recessive genetic disease. How do we prevent it? Well, there are different issues or problems or uncertainty that are tied with the use of expanded carrier screening panels. These are 3 main ones, but if we open the discussion, we can come up with a few more. One problem or one issue that we should discuss is cost effectiveness. The other one is the need of coherent testing panels. And the last one, which is very much near and dear to my heart, because in the clinics we live this every day, is what we mean by actionable information. So cost effectiveness. There are several studies related to cost effectiveness of ESC. The very truth is that prospective study, real life study in large population about the use or implementation of this panel are still ongoing. We don't have a final answer. we have to recognize that cost effectiveness, like I said, is not fully established, and the models that seem to indicate that yes, these tests are indeed cost effective, they are subject of many variables. And for instance, it depends who's paying for the test and how much are they paying, how big is the panel, how many diseases are included, what kind of population is tested, etc., etc. So within recognizing all these limitations in the theoretical study and recognizing the fact that we don't have a prospective, conclusive answer, it seems that expanded carrier screening could be cost effective. One problem that is appearing more and more as we go on in the use of this panel is the lack of coherent panels. Currently, testing companies are basically proposing different panels that are mostly related to, of course, guidelines, but also the desire to acquire a part of the market, and therefore they are somehow personalized or somehow specific for a specific company. So we see here 5 different companies operating, in this case in the Spanish space. They have different number of genes in their panel, and so our colleagues here in Spain, they have made this exercise and they looked at how many of the genes that each panel is testing are overlapping across panels. So how many of them are common, how many are the same. And unfortunately, out of about 950 genes that one way or the other are tested, less than 100 are common in all panels. So about actionable information. Well, actionable information is a very important and interesting concept, and sometimes is not so straightforward. Like I said, what usually people think about, especially if the couple is already going through IVF, is coupling IVF with embryo diagnosis in the form of PGT-M. PGT, as we mentioned, is pre-implantation genetic testing. It can be M for monogenic disease, A to detect aneuploidies, or SR to detect structural rearrangement in the genome. The one that is problematic in a sense is PGT-A. PGT-A is to detect aneuploidies, and in women of advanced reproductive age, meaning over 35-year-old, there is an increase in aneuploidies in the embryos, and therefore often the couple is already thinking or is already proposed PGT-A when PGT-M comes along. To summarize problems and uncertainties, well, this is what we just discussed, and let's go a little bit deeper into the actionable information. You see here an embryo, a human embryo at the blastocyst stage. This is at day 5 or 6 of development. You see on the outside something that looks a little bit like a shell. It's called ZP, zona pellucida. Inside you have the embryo, which is a fluid-filled cavity. At the outside you have a very thin layer of cells called trophectoderm, here designed with TE. And at hour 5, you see a very compact cluster of cells called ICM, inner cell mass. The ICM will be basically the cells that will give rise to the embryo proper, to the fetus, while the trophectoderm give rise to the embryonic contribution to the placenta, and is the part that is biopsied, so is tested when you do a PGT-M in an embryo. And this is what we are going to see. While the embryo is developing, the embryologist will make a small hole into the zona pellucida, and when the embryo arrives at day 5 or 6 of development, because it escapes a little bit through this small hole and protrudes a little bit. And this part that protrudes is the one that the embryologist collects and makes a little bit weaker with the use of a few laser pulses, and then detaches completely through a flicking movement and sends to the laboratory for DNA analysis. And I would like to show you now exactly a video of that. What you see here on the right hand side is the pipette of the embryologist. On the left hand side is the portion of the embryo that is outside of the zona pellucida, and you see a target sign. That's where the laser is pointing, and you will see, I will tell you when the laser is actually shooting the pulse. So we see that the pipette is approaching the protruding part of the embryo. The embryologist is aspirating a few cells. You will see that the fluid cavity, as soon as the continuum of the cells is broken, will start to collapse. The goal for the embryologist is to collect between 5 and 10 cells, no more. If you collect less than 5, the test will be non-informative. If you collect more than 10, you will start damaging the embryo. So once a sufficient number of cells is inside the little tube, you will see that there will be 3 laser pulses. The laser pulse is not, no, this is one, is not meant to break completely these cells, but simply to have the embryo retract a little bit so that the cells will then be separated by flicking. The flicking is not present in this video because it needs to be done at a different magnification, so we will not be able to appreciate, but this is how a PGT-M or a PGT-A is done in our clinics. So what are the open questions of this technique? The embryos that are affected, of course, are not transferred. What do we do with embryos that are just carriers? Should we transfer them or should we not? If we transfer them, we have higher chance of pregnancy, but at the same time, we would also transfer the possibility in the next generation of a match with another carrier. Should we couple PGT for monogenic disease with PGT for aneuploidy? Of course, if you select embryo for aneuploidy together with them being free from the monogenic disease, you will have a higher pregnancy rate for every embryo that you transfer because they are very selected. However, if you continue to select too many embryos, you will have less number of embryo transfer. And it is true that you are using the same biopsy, so you are not damaging the embryo specifically for one thing or the other. But it is also true that often this patient, the patient that have an indication for PGT-M, they're not necessarily at high risk of aneuploidy. And so is it justified to couple, two assessment when you really need only one? Another question that is perhaps very relevant in Europe, not so much in other parts of the world, is what condition should we do PGT-M for? In Europe, it's pretty established. We only do it for serious disease, early onset, for which there's no cure. But in other parts of the world, specifically in the US, you can do PGT-M for basically anything, for literally anything that you consider being, reason enough to select the embryo. And one problem that is directly tied with the previous one is, what if we have a couple that have a higher reproductive risk because they've done the test and they found that they're both positive for a certain mutation, but this higher reproductive risk corresponds to a disease whose phenotype is considered relatively mild? Should they go through all this technique and all this cost and all this embryo selection to avoid a mild disease? So let me close with 3 clinical cases that I would like to present just for you to have a point of reflection and take home with you. So in this first case, we have a couple that come to the clinic and they come for infertility reasons, meaning they have a factor they cannot get pregnant. They are offered as part of the regular visit, expanded carrier screening with a commercial panel in order to lower the reproductive risk. The couple turns out to be positive for the same disease, which carries a health burden. So, PGT-M is proposed. Unfortunately, the disease is not considered serious enough, and the national authority denied the permission for PGT-M. So this couple came, They had no idea that they were carrier for something. They are informed about this test. They decide to take the test and then they get stuck. Now they have a problem and they don't have a solution. In another case, we have a couple that comes to the clinic again for fertility reason, and the reason is that the woman is of advanced maternal age and she cannot get pregnant because the quality of her oocyte is getting lower. While collecting the clinical history, it emerges that the couple already had 2 children years back, of which one died by a sudden heart attack at the age of 12. It's a very young child. And in relation with the death and autopsy of their child, it emerged, and the husband is diagnosed with a disease, with the dilating cardiomyopathy that he, of course, had in a milder version. But this dilating cardiomyopathy is a dominant genetic disease, meaning that the couple has a 50% chance of having a disease, another disease, child. So the couple is proposed PGT-M in order to avoid the carrying a pregnancy with an affected fetus. And after much deliberation, the couple refuses. And their reasoning is that we are used to live with this disease in our family. The husband almost took umbrage to the idea that someone like him may be selected out by PGT-M. The third case, and the last one, it's about a couple that attend the clinic specifically for PGT-M, because the husband carries a dominant form of polycystic kidney disease, so he's himself affected. He needs, in fact, dialysis twice a week, even though he's relatively young. So they know, and they don't want to carry this disease to the next generation. Given the age of the woman and the fact that the biopsy on the embryo is already been done for PGT-M, the couples choose to undergo also PGT-A, so to check also for aneuploidies and not just for the disease. So the process is done, the biopsy is taken from the embryos are frozen, waiting for the answer from the laboratory, and the test is run. And while the test is being done, the couple communicates to the clinic that in case of no euploid embryos, so in case PGT-A does not return any euploid embryos, they would like to have an affected embryo transferred instead. So they prefer to have an affected embryo for sure for polycystic kidney disease as long as it's euploid, rather than not having a transfer. And how do they justify this? They say, we know that we can manage this disease, but we don't think that we can manage a trisomy. So I leave you here with just a few words for further discussion. Expander carrier screening represents a significant shift to preventive medicine in assisted reproduction. It is a way of testing that is more inclusive, it's pan-ethnic, and it doesn't, restrict the possibility of limiting your reproductive risk to certain groups. It's likely cost-effective, but information and counseling of patients is absolutely critical. PGT-M, again, is also very effective in avoiding the birth of affected individuals, but coupling with other techniques can become quite problematic. So I'd like to finish here my presentation, and I'll be very happy to open the discussion, which can be gone, of course, here during the symposium, but further, I'm very much open to discuss this online through my handles in Twitter and in LinkedIn. Thank you so much to all.